Good morning, everyone. Thank you for joining us today. My name is Georgia. I'm the Project Support Officer for the Paediatric Integrated Cancer Service, and I will be acting as your moderator for the session today. I would like to begin by acknowledging the traditional land owners of the land on which we are virtually meeting today, the Wurundjeri people, and pay my respects to their elders past, present, and emerging. Today is the third of 4 sessions designed for allied health administrative and support staff as an introduction to paediatric oncology. In the first session, we covered paediatric cancer in Victoria and types of childhood cancers. Last week, we covered treatments for paediatric cancer and side effects of treatment. If you missed either of those sessions, we will circulate links to the recordings in the post-session email that will go out later this week. Today, we will be hearing from Dr. Maria McCarthy, coordinator of the Psycho-oncology program at the Children's Cancer Centre at RCH. Maria will be covering the psychosocial impact of childhood cancer on patients and their families. Before we get started, we've just got a little housekeeping. So we will be attending to questions both throughout the presentation and at the end. We ask that you submit your questions via the Q&A function in Zoom at the bottom of your screen rather than the chat function. However, as this is an open session with staff from multiple health services, we just ask that you refrain from including any sensitive patient information in your questions. Please note that the slides will be circulated in the post-session email later this week, along with a recording of the session. So you don't need to take notes if you do not wish to. Without further ado, I would like to hand over to Maria to take us through the session.
Thank you so much, Georgia. I'm just going to share my screen. Thank you, and thank you everyone for joining me today and being willing to sit on your computer and listen to me for the next hour. Welcome to everyone. I'm here at the Royal Children's Hospital, but I'm aware that there's colleagues from Monash and Peter Mac and regional centres. Just by way of introduction, I'm Maria McCarthy. I'm a mental health clinician here in the Children's Cancer Centre, where I've worked for around 17 years, I think. I do manage the Psycho-oncology team here, and I'm also a research fellow with the Murdoch Children's Institute and do a lot of psychosocial research that really informs the work that I do. So I'm very glad to be doing this session today on behalf of PICS, just by way of what the intended outcomes of this session are. One is to give you a kind of a brief overview of some of the theoretical frameworks for understanding family responses to childhood cancer. That will be fairly brief. And then just talking about the common responses that we see in patients and families. I'm going to talk a little bit about trauma-informed practice, and I think that's very important for us to have a shared notion of what that means as allied health clinicians. And I've also been asked just to talk about self-care needs for oncology healthcare professionals. When I was putting these slides together, I actually went back, I actually came across the feedback from this session a couple of years ago, and the feedback was very nice, but there was lots of requests for more information. And so these are some of the topics that people asked for more information about. So I'm just putting this up because clearly I'm perhaps not going to meet everybody's needs in talking about psychosocial oncology in 1 hour today. So what I do suggest is if there's topics that you really would like to hear more about, that you let Georgia know, and that maybe that's an opportunity for PICS to schedule some more sessions. The other thing is I'm very happy to put together a reference list. And so if there's topics that you would like to read more about, I'm really happy to send that out to participants. So what I am going to do is try and meet those learning goals. But I think what I will focus on is giving you a little bit of my personal experiences or my anecdotal experiences of how I might work with children and families, and in particular, how we perhaps communicate with families in what is an incredibly difficult situation. So I think it goes without saying that a diagnosis of cancer in a child is almost inevitably traumatic for a family. And for many years, I've been showing this picture done by a young child who, instead of calling it cyclophosphamide, which is the chemotherapy, she referred to cancer as cyclone phosphamide. And it really is somewhat of a cyclone or a tsunami for families when a child is diagnosed with cancer. And that's because it's obviously a rare disease. It represents a threat to the life or the body integrity of the child. And we know that that's a hallmark of a traumatic event. We also have a lot of associations of what cancer means. In particular, I think we all have been socialised to associate cancer with death and dying. And so it engenders a lot of fear. It's a diagnosis that engenders a lot of fear. And also when children get cancer, it is what, I would regard as against the world order. We expect this to be a disease of older people. And that's particularly the case for families when they try to come to terms with their child's diagnosis. In terms of some of the models that we've used to understand families' response to cancer, this is a very old model, the Socioecological model of child health, but it is as relevant now as it was in the many years that it was developed. And really it tells us that children live in families, they live in communities, and when we meet a child with a diagnosis of cancer, or similar blood-related disorder, we are really meeting the whole family, and we are really having to think about all of the family members and the community, including the school, the social networks, peers, etc., and out to those more distal elements around culture and society. So this is, I guess where our notion of family-centred care stems from, and hopefully we all practice in that way. I think another theoretical framework that's incredibly helpful for us understanding responses or how children and families might adapt to a cancer diagnosis, and in particular treatment, is that of attachment theory. And I'm not going to go into that in great detail, and I'm sure many of you are very aware about attachment theory, but essentially it is an instinctual human behaviour of how humans respond when they are faced with a threat. And for infants, we see this in terms of their bonding or connection to their primary caregivers and how they might seek those out when they perceive danger. So we often talk about the importance of children having a secure base. So this is the early kind of experiences of their world where they can gradually explore the world, seek comfort and reassurance from their primary caregivers, and then which allows them to understand that the world is a safe place, and then to continue to explore. And potentially a diagnosis of cancer really can disrupt this notion of secure base in children. And so it's a very important thing for us to understand. So children who are securely attached will show sort of fairly predictable behaviour. They may be distressed at separation from their parent, but they will calm quickly and they will show increasing autonomy. Unfortunately, we also see children whose attachment is not secure. So it could be anxious or avoidance. And these are children that we might see that really seem to struggle to adapt to their treatment might not be easily comforted or calmed, and really may be very hypervigilant within the hospital setting. And finally, just another really important framework for us to think about is the notion of paediatric medical traumatic stress. And this is really just a framework for helping us understand that children and families respond in particular ways to the experience of medical procedures, frightening experiences, hospitalisation, and understanding traumatic stress and responses to that really can help us understand how we might target our interventions to families. And there is lots of resources, lots of resources, particularly in the National Child Traumatic Stress Network, that you can look around about to learn more about this. So if we just very quickly think about the common impacts upon children and families when they're diagnosed with cancer, well, as I've said, it's potentially a traumatic experience, not just the diagnosis, but really the multiple procedures and treatments that children will face. I've mentioned the loss of a secure base. They have to, there's a significant disruption to routine and familiarity, adapting to the hospital environment. And I guess one of the really difficult things for children, or potentially difficult things, is the unpredictability of their world. And that is where we really need to look at how we can actually make it more predictable and a safer place for children. Obviously, they'll undergo significant physical changes in their body, they're isolated from their peers, and importantly, there is significant disruption to education. If we think about the impact on parents, and this is where the title, this image is where the title of this talk comes from today. This is an image drawn by a parent a number of years ago called The Daunting Rollercoaster. And a lot of parents will talk about feeling like they are on a roller coaster, alternatively feeling more optimistic and hopeful about their child's diagnosis and prognosis, and at other times feeling very worried and, as depicted in this image, broken-hearted. So parents will inevitably experience sadness and grief at their child's diagnosis, and we also see guilt. So often at the start, in early stages, parents may actually be seeking an explanation for their child's illness, and that often can manifest as guilt. Is it something we did? Is it something that I ate in my pregnancy? All sorts of things that parents might question in trying to make meaning around their child's diagnosis. I think one of the most challenging things for parents is managing uncertainty. And even if their child has a cancer with a relatively or very good prognosis, parents still sit with the uncertainty that their child may be the one that relapses, that their child may be the one that doesn't respond to therapy. And so this is a really challenging aspect of their child's treatment, is this uncertainty. I think many of you will be aware of the physical impacts on parents, the sleep disturbance, being in the hospital, on the wards, the changes in roles. Very often one parent will stop or reduce work. And I think an important thing for us to remember as health professionals is their changed role in parenting. And often this becomes a very public role where parents are, I guess, on display for all of us to see. And if we think about that, that's a really challenging thing to have to endure. And I think we need to be very mindful and respectful of how parents manage that. And there's a lot of research, which I'm not going to go into today, which actually says that parents are at most risk for post-traumatic stress symptoms related to their child's illness and treatment. I just want to briefly mention siblings. Sometimes we don't all get to think about siblings very much, but siblings will have their own response to their siblings' cancer diagnosis, and we know that they are potentially at risk, particularly for things like changes in their own school performance, feeling somewhat jealous of their sibling that may be getting a lot of attention, or alternatively feeling guilty about that. I think we do need to be mindful and check in with families around how siblings are doing. I do remember very early in my career working with a young boy who was about 8 or 9, and he was a sibling. His sister had cancer, and his behaviour had become incredibly disruptive. And I actually worked for him for quite some time, and it took several months really before he revealed to me that he thought that he had caused his sister's cancer in a physical fight that they'd had before she was diagnosed. And I think that was a really seminal moment for me to understand that we really need to check in on siblings' understanding, in particular siblings, I think, who might be of an age around 7 or 8, who may have what we call magical thinking. So they may be thinking of, they may have explanations or come up with their own theory of their siblings' illness. And really important that we check in, even if we're not seeing siblings, checking in with parents around how the other children in the family are managing. And I just do briefly want to mention grandparents who, again, we don't always see in the hospital, but who have what we call a double and silenced burden to bear here. So the double worry of worrying about their own child and their grandchild, and often silenced in the sense that they don't get the opportunity to talk to psychosocial health professionals or seek help for themselves. And so they're an important extended family members that we need to think about in our family-centred care. So I guess it's pretty clear that the cancer diagnosis has a very significant effect on families. However, I think the good news is to know that resilience is really a common response. And so whilst we may see a lot of distress, a lot of challenges in adjusting to the new circumstance, the research suggests that about 75% of families and children will go on to do quite well from a psychological perspective. And I think this is a really helpful thing for us to keep in mind. And often as a mental health clinician, when I'm seeing families, I can see that there's a real worry for parents that, you know, is my child being damaged? Will they ever recover from this experience? And I often find it really helpful to say to parents, you know, I want you to know that most of the children that we see here will go on to do well. This is an enormous experience right now, but psychologically we know that many children will adapt and do well. And that can be a really reassuring message for parents to receive, particularly in the early phases of diagnosis. However, of course, that leaves us with you know, somewhere between 20 and 25% of families who will continue to experience ongoing distress, and that may continue for many years post their child's diagnosis. And so I guess this is where the social work team and the mental health team tend to get involved and do a lot of our work around families where this diagnosis really has disrupted their trajectory for whatever reason. So I guess given that we can talk about resilience, I think it's really helpful then for us to think about our work as allied health clinicians or psychosocial clinicians from a strengths-based perspective. And so I think if we can think about families as having the resources within themselves to manage this difficult situation, that they want the best for each other and that they are doing the best that they can. I think it's very easy for us to become quite judgmental about how families adapt. And so I think if we can use this framework, it really sets us up to work well with families. And also to really understand that every family is unique in the way that they'll make sense of their experience, and that we, you know, our job is to be really engaged and interested and curious about what resources they can bring to this situation. Having said that, I think that, excuse me, I'm just going to fix my screen here. covering up my slides. Having said that, I think there is red flags that we do need to be aware of. And these are what I guess are the risk factors that really make us as psychosocial clinicians perhaps explore a little bit more with families about their capacity to adjust. So the things that will impact or disrupt adjustment are things like family conflict. That's fairly self-evident, and particularly where we see separated families or step families within the hospital environment, that where the relationships are conflictual, that can create a lot of difficulty for both the families themselves, the patient, and indeed the staff. Where there's been a mental health history, either in the child or the parent, that's something that we need to be aware of and explore. We know that social support is a huge protective factor for families, and so that is something we need to explore and understand what is available to them. And of course, in this time of COVID, this is what we've seen, the usual supports that families may have really been non-existent, and that's been a huge adjustment. Children may come to us with developmental differences or disorders, and this will really impact on how they're able to adjust to their diagnosis. And this is really important. And obviously, as allied health clinicians, we are very well trained to understand children's development and to be able to utilise that to help us think about our therapeutic inputs. We know that financial resources are a huge issue for families, and in fact, there's a whole field of research around what's now called financial toxicity associated with cancer. And financial difficulties are very much associated with parental distress and a really important factor for us to manage. Families may come to us with a history of loss or trauma, and so their child's diagnosis or may trigger or re-trigger that traumatic experience. And we need to think about particularly families that may come from refugee backgrounds or other backgrounds that may have been quite traumatic. And also, of course, there is cultural differences, not just language barriers, but other differences that might really make a family's adjustment more difficult, and that we need to be mindful of. So why is this important? Oh, sorry, I've gone ahead. So a little bit of a take-home message before, after all of that. And that is to say that, in fact, it is the psychosocial factors rather than illness or treatment factors or even demographic factors that tend to predict how families will adjust. And this research particularly, fact particularly holds for parents. So whilst we think it might be, the intensity of the treatment or other sort of socioeconomic factors, it's actually their psychosocial well-being that really will guide how well a family will adjust. And I think this is really important to remember. So, and in particular, because we work in a medical model, and often in a medical model, risk is assessed in terms of the risk of the disease. And so sometimes you might hear a phrase, I hope you don't hear something like this anymore, but oh, she's just a standard risk Luke, or it's just a Wilms tumour. And I think that kind of language, number one, is not great, but also really doesn't reflect the psychosocial risk of a family. And I always remember when I was doing my PhD, and one of the most, was looking at post-traumatic stress symptoms in parents of children with cancer. And one of the most distressed mothers in my cohort was a mother of a child with a Wilms tumour. So a disease that is highly curable, has a very short treatment period. And so we really need to be mindful of not judging what we expect from families in terms of the type of illness or the type of treatment they may be having. So what is important? What's important is understanding the subjective appraisal that families bring to their situation. So often the subjective appraisal, particularly for parents at the start of or early in a diagnosis, might be, this is terrible, I don't know how our family is going to cope, I don't know how I'm going to cope. And you'll hear this kind of subjective response to their child's situation. Over time, that usually what we see is that adjusts, and parents and families are able to make meaning and to be able to come to terms with not accept their child's diagnosis, but to be able to work with it and understand that this is something that's happened to them and to their family, and that they can manage this. What we do know, however, is that an initial level of distress, so families that are highly distressed initially are often those families that may continue to struggle. And so that's an important thing, marker for us to be aware of. And clearly, either children or parents that come to us with pre-existing anxiety or sort of personality features, if they're, if they tend to be a negative thinker rather than an optimistic kind of person, those kind of factors will really influence how they can adjust to their circumstance. And whilst I've said that the medical factors do not usually drive families' responses, the exceptions to that are when a child relapses. We know that when relapse occurs, for instance, that parents are 3 times more likely to experience post-traumatic stress symptoms. And so that require, things like relapse or major shifts in a child's prognosis or circumstance really requires us to reassess that family from a psychosocial perspective and understand where they are at that time. And obviously, if there's very major changes to a child, whether that be a leg amputation or significant neurocognitive impairment, that's when disease factors or treatment factors really are important to understand and to help families work with. Just this quick slide is just to talk to you about the fact that there are multiple trajectories of recovery, and I'm talking about psychosocial recovery for families. This graph really comes out of work done by a grief researcher, but we've replicated this kind of graph in work we've done with looking at adjustment of parents of children with cancer and other chronic illnesses. And so what we see is there's different patterns of response and recovery. The blue dotted line is, I guess, what we see commonly in a cancer diagnosis. So high level of distress at the beginning of, and particularly in the first year of a child's diagnosis, and gradually lessening distress over time. However, we also see families that are highly distressed, and parents, in particular parents that are highly distressed, and continue that in what we call more of a chronic group. And we also see, of course, commonly a resilient group. So families who may experience some distress, but are able to manage that in really adaptive ways and seem to be able to cope well. We perhaps less often see the delayed trajectory there. But I guess it's important to realise that we don't know when we meet families in this circumstance, perhaps what their adjustment trajectory looks like. And part of our job is to work with them to understand that. So I just want to mention quickly the notion of trauma-informed practice. And I think this is something that everyone who works in oncology should be taking the time to think about and inform themselves about. And essentially, trauma-informed practice occurs when the whole system, and that when we're talking about a system, I'm talking about the whole cancer centre that you may work in, or the paediatric ward on your in your regional hospital. The whole system is geared to think about what is potentially traumatic for children and families in a hospital environment, in a treatment environment, and how we can minimise that distress. And so there is, as I said, lots of resources around this to think how we think about the D, E and F. So think about a child's distress, provide emotional support, and think about the family. So I won't go into this in great detail, but I'll kind of give you an example of what that looks like in a very brief case vignette. But really everything that we should be, every interaction we have with families should be focused on how we can minimise their experience of trauma. It's also really important to realise that what is traumatic for one person or what is difficult may not be the same for another. So we really do have to assess this. And this is results of a very old study that was done a number of years ago, where they asked cancer survivors what was the worst thing about having cancer, and they asked mothers the same. And as you can see there, for the children who'd had cancer, actually it was needles and losing hair that was the most distressing thing for them, and that they actually didn't worry about relapse or death. Whereas for mothers, the worry about relapse and being frightened of their child dying were really the most common responses. So parents and children will be worried about different things, and we need to be able to understand what that is. So obviously, when we talk about potential for trauma in the cancer scenario, of course, the intensity and frequency of the medical procedures that children have really are a source of potential trauma. And those of you who know me will know that I am a passionate advocate for good management, good procedural pain management, and management of distress. And I think for allied health staff, this is really where our work should be. We need to be aware that even very young children can be prepared for procedures. How we talk about treatments and procedures is really important, and that many staff contribute to reducing trauma for children. So child life, music, art therapy, and of course at Monash and at the Children's here, our Comfort First programs are all about reducing procedural distress. But I think it's really the job of all of us to advocate for good procedural pain management, and when we see children who appear to be distressed, to advocate for them and really work towards, appropriate planning and prevention. So just to give you a very quick example of what this looks like, this is an example of a 6-year-old boy who was referred for a bone marrow transplant to the cancer centre. And this was a boy that had had many cannulas previously because of his blood disease, and had previously coped quite well. But coming into the cancer centre, he had a Hickman line insertion and became very distressed around dressing changes. Developmentally, he had some challenges in terms of attention difficulties and hyperactivity. And so here's a sort of typical scenario where a Comfort First would become involved and particularly start to work around medical play and preparation and planning for a child like this. In this particular case, the child will do a lot of trying to delay the procedure, so asking a lot of questions, using a lot of tactics to try and delay the dressing change. And his parents were also really struggling to know what to do, so apologising to their child and perhaps giving their child more control in that circumstance than was appropriate. So again, this is where Comfort First would use a number of strategies, procedural schedules, behavioural strategies, parent education to help that child adapt. And this particular Comfort First clinician kept track of this child responses, and you could see at the start the amount of time it was taking, so that's the red graph going up to the top, in order to get the dressing change done, and how that improved once there was a Comfort First intervention. However, when the child came into transplant, again thinking about secure base, a new set of circumstances, that child's distress started to increase again, and Comfort First needed to become involved again and help that child adapt. So this is a good example of, we need to assess patients and monitor and reassess as needed, and that a lot of our work may be quite episodic as children face different circumstances as they go along. I just want to give you another case very briefly. This is a very different case. This is more around mental health referral, and I will talk about why I selected this case in a moment. But this is a scenario of a 12-year-old boy who was diagnosed with ALL. He had a really difficult induction period and was admitted to ICU twice and in hospital for 8 weeks. He was referred to me for behavioural difficulties. The staff said that he was having really disrupted sleep and separation anxiety. Even though he was 12 years old, he couldn't let his parents leave the room. And the staff had the perception that the parents were really just doing everything for him, and that they were so anxious that, you know, they felt that, staff felt that the parents may have been contributing to this boy's difficulties. When I met with the parents initially, they described their child as a well-adjusted boy. He had been flat and withdrawn following his diagnosis, but now they described him really as very regressed and much more like a younger child, and that the sleep disruption was really significant. He was still an inpatient at this stage. When I assessed him, I was able to see the separation anxiety. Obviously, he was also doing some really unusual behaviours. So he was groaning a lot. He was sort of rubbing his fingers. He was swearing a lot. And he was also at times playing with his penis while I was there, which is not a really typical behaviour of a 12-year-old. So when I saw this, I came back to the team saying, you know, I'm not so sure that this is a behavioural issue. And as a result, the medical team did an MRI, which was normal. But I also made a referral to our psychiatrist here, and we did some further assessment together. And that assessment showed that this boy's behaviour really had changed over the past 5 days. He was really quite agitated at times. He was waking up at night, quite confused, not knowing where he was. And he was doing some behaviours such as singing that his parents had never seen in him before. And also the parents were quite reluctant to discourage any of this behaviour. What we ended up diagnosing was, in fact, that this boy had some delirium, which was related to his ICU stay, and presumably many of the very powerful drugs that he had as a result of that. And we do see this delirium in children that have been in ICU. It commonly occurs in adults as well. And so we were able to say to the medical team that this is what we thought was going on. And as expected, this boy just recovered in over time and was able to return to his more normal functioning. But I wanted to illustrate that case to just say to you, we need to be really mindful when we observe and assess children's behaviour, that there may be many medical factors that are contributing. And as mental health clinicians, we often see this with pain, and we often have staff say to us, oh, we think this pain is psychological. And of course, there's always a psychological component to pain, but I think we need to be really mindful that there may be many or multiple factors that may influence a child's emotional response and behaviour. It also doesn't mean that we can't use our usual interventions. So we may still work to help with good sleep hygiene, support parents in this case, look at strategies to reduce a patient's agitation and distress. But I just want to make the point that we need to be thinking very broadly when we assess children. I just wanted to pop this slide up for you. This is as a way perhaps of thinking about the scope of work that allied health clinicians and psychosocial clinicians do. This is a model that I've been working on that's come from Lynn Gillum and the bioethics team. And we've been doing a project looking at truth-telling with children and what we should, what children should be told around their serious illness and treatment. And we've come up with this model of thinking about what are the important factors, or what are the interests that a child has, and how does their diagnosis or how does their treatment impact their interests. And I think it's just a really helpful model for us to think about, that we may be targeting different aspects of children's interests in whatever role we take in working with the child. So for instance, this model says that a child has, right to basic needs and protection from neglect and abuse. If we were concerned about that for a child, clearly there's a strong role for social work to be very involved with that family and to ensure that that child has a safe environment. If we are working with a child that has been in hospital for many weeks, a young child, we may feel that actually the experience of play is actually going to be really important for that child. And so child life therapy is a really important therapeutic intervention at that moment. We might, when we're doing good procedural pain management, be thinking about how can we give a child more of a sense of control over their environment? How can we give them some sense of agency in what's going on with them? So I think this is a really helpful model, and I think a lot of the domains here are the domains of the allied health team, to think about the interests of the child and how we can meet those interests in the circumstances that they are in. Okay, I want to move on now and talk a little bit more practically about how you might interact with families that you meet. So whilst I've said that many families, the majority of families will ultimately be resilient, that doesn't mean that they're not distressed, and that you will see families, you'll see children who are distressed and parents who are distressed. And I guess when sometimes when we see particularly parents who are distressed, there'll often be a call to social work or to mental health to say, can you come and see this parent, they're crying. And that may be an appropriate referral, but at other times it may be that that parent just needs to express some emotion or is having a bad day. And I think we all need to be able to work with families who are experiencing distress. So essentially, what does that mean for all of us? Well, I think we need to remember that we are meeting families in incredibly difficult circumstances. So what can you do? I think that very much we all need to be working towards establishing a relationship with any child and family that we meet. Developing rapport is incredibly important. Sometimes people will say, well, I don't have time. And I think that's an error, and we always, even in a very short time, can find ways to connect with a child or with a parent that will really help us with our therapeutic relationship. It's also really helpful to think, what do I need to know about this family in order to be helpful? Sometimes I think we forget to ask questions about whether it be a child's learning style or how much information they might like to have, or what works for their family in terms of communication, etc. And I think that is a really helpful thing. So saying to a child, how do you like to learn? Or are you someone that likes a lot of information or only a little bit of information, will really help us target our interventions. And also to be thinking about what is your job, what is your role, what can you do for this child and family, and what is beyond your scope. And the other thing, I guess this is self-evident, but the importance of good communication, the importance of really listening carefully to children and families, and also responding carefully. And I really do believe that every interaction we have with families and with children has the potential to have a therapeutic impact. So really important that we do that well. So I thought I would give you, this is a little bit of a framework that comes from St Jude Hospital from Justin Baker. And I think it is a really quite helpful acronym for particularly for staff who feel, look, I haven't really been trained so well in delivering psychosocial care, and sometimes I feel a bit overwhelmed when I walk into a patient's room or meet a family that is really distressed. One of the really helpful things that you can do in that circumstance is simply to name the emotion. So I think one of the things that staff will often find difficult is if they kind of encounter a parent that is angry or upset. And one of the first things that really is a good thing to do is just to notice that and say, I can see, or it seems like that you're feeling really frustrated today, or that you seem really upset. Just naming the emotion and taking a pause and listening to the response is often really helpful to help understand or to meet that child or parent where they're at. Also demonstrating understanding, and this is particularly important about how we demonstrate understanding. And I will give some examples of this in the next slide. One of the things we shouldn't do is say, I understand how you feel, because of course nobody understands how that parent or that child feels, and there's better ways that we can say that. Giving families respect, acknowledging their emotions, and offering praise where appropriate, supporting the family or the parent or the child, and exploring some more. So I'll give you some examples of that. So an example of naming the emotion would be to say, it looks like you're worried, and then pause and see what the response is. Sometimes if you say something like that to a parent, or if you say it looks like you're upset, they might say something like, I'm just having a bad day, or I'm just having a moment, and that's fine, and that will help you understand this. Perhaps you need to offer support, but this isn't necessarily a scenario of needing to call the social worker or the mental health clinician. But also offering understanding. I can see why you would feel worried about that, is a way that you could respond. Offering respect. Anyone would feel concerned if they were in your situation. And I think that is also an opportunity really to normalise a lot of responses from children or parents, who perhaps think that they should be able to cope better. It's really normal for families to experience strong emotions in the circumstances. And I think this is also an opportunity to also remind parents or what a good job they're doing, and offer praise, or offer praise to the child about, even if they're having a difficult time, how well they've been, whether it's doing their physio or whatever it might be. If you think that, from this conversation that the family do need support, then you can say, I'll find out some answers to your question, or I will, is it okay if I give the social worker a call, etc. And also the other thing to do is, if you're not sure what to do, asking a parent or a child, can you tell me some more about that, will often give you the clues that you need to know how to respond, and to know whether this is perhaps just offering support in that moment. Or often I'll say to families, thank you for sharing that with me. This seems like something that would be really good to talk to your consultant about. Would you be okay if I mentioned this to her, and that so that she could come and have a chat with you? So that's kind of, I guess, the nurse acronym is a little way, I guess, a helpful way of thinking about what strategies you can use in talking with families, children and parents who might be distressed or be experiencing anger or other strong emotions. And I would just like to say that the same thing applies in terms of families who might be experiencing either bad news, or families whose child might be facing end of life. Always acknowledging a loss is really important, and whether that be coming in and saying, I heard in the meeting today that the scan results were not good. I'm so sorry. And again, using silence and a pause to let the parent respond to you and see if they want to talk about that, or they might just say thank you. And I guess showing that level of concern is really important. And then asking, is there anything that I can do today that could be helpful? Is there anything else that you need? And what is really important in all of these conversations is that you really are authentic in your interactions with the family, and that you are offering genuine care and empathy. Just in the interest of time, I'm going to skip over, maybe we do have a little bit of time. I guess one of the things about working with families whose children might be no longer receiving curative treatment is that we actually have a lot of information now from research, in that we know what parents need from us in that circumstance. So that example that I gave just on the previous slide of being able to acknowledge their grief and loss is really important. Families need to know that their child is cherished and loved, and we can express that to families in all sorts of ways. We can offer comfort, we can remind parents what a good job they're doing in looking after their child. We can talk about the fact that everything that is being done for their child that can be done, and these are all things that parents have told us that are really helpful from healthcare clinicians when they're facing really difficult, either the death of their child or relapse or other circumstances. So there's a lot we can do, and I think sometimes we feel like we want to avoid meeting those families, and that's really important that we feel comfortable to offer comfort and support. Okay, I'm just going to finish up very quickly on a couple of points about self-care. And I feel for many of you, you will be very mindful, particularly in these COVID times, about the importance of self-care. But I will touch on this a little bit, and then we'll have a few minutes for questions. So I want to just say my perspective on healthcare is that the oncology context is very unique in terms of the relationships healthcare providers have with families. We tend to get to know families very well. We actually may see them for many years. And so really, most of oncology care is about relational care. We are in a relationship with that child and family, as I said, often for a long time. And to a certain extent, we have to feel love and care and empathy. Not to a certain extent, to a great extent. And sometimes when I say that we need to love our patients, people can, I don't mean that literally. I'm not suggesting that you tell patients that you love them, but you demonstrate that love and care, and that you really show that you are very invested in that child's well-being and that family's well-being. And I think this is the reason why, despite the fact that oncology context is very difficult, people often stay in the field for a very long time. And you may have friends or family that say to you, oh, I don't know how you can work in that area. I don't know how you can work with children with cancer. Well, I think we can do the work because often we are privileged to have relationships with children and families and to walk alongside them through what is a really life-changing experience. But because of those unique relational experiences we have, I think that what that also means is that boundaries in terms of our professional relationship with families become more important than ever. We need to be really mindful of how we express our love and care for our patients and families, but also have really clear boundaries around what we share with families in terms of personal information, when we find ourselves perhaps going the extra mile for a family, making sure that that's for a good and authentic reason, and not because we're becoming perhaps over-involved or we're responding to some other aspect of that family. So I think understanding, and many of you will have sort of good ethical training around what that means for your profession. Reflective practice and supervision is incredibly important. I know not everybody has access to that, but using your peers to talk with your about your responses to children and families, and how you might understand that is really important, and knowing yourself very well. So knowing what it is about your work or your personal circumstances that may make you or that may impact on your relationship with your patients or families. I'm not going to go through the symptoms of work-related stress. I'm sure you're all very aware of those. But I think what's really important in terms of self-care is to make sure that you have a care plan that works for you, so you know how to look after yourself. Sometimes that is really just about having rituals. It might be about not taking your work home, or taking a shower when you get home, or listening to music on the way home, whatever it is that helps you separate your work from your home life. We know for a lot of people that practicing gratitude, this is not for everyone, but can be a very helpful way of managing stress. And also just one small thing is doing something or savouring something that you really like to do each day, whether that be really savouring that cup of coffee in the morning. This is a sort of form of mindfulness. It doesn't have to be anything really significant, but it can be really taking notice of doing something that you enjoy each day. And also knowing that there are definitely supports for you if you are experiencing stress and distress in your work context, talking to your supervisor or manager, utilising services such as the employee assistance program. But I guess the really important message is that we need to fill our own cup in order to be able to do the sort of work that I've been talking about with our patients and families. I'm going to stop there and thank you, and I will see, I think we've got about 4 minutes, Georgia, if there is any questions that you would like me to answer.
There haven't been any questions that have come through as of yet. I will leave it a couple of minutes and see if anybody has any they would like to ask. Just a reminder that our final session is next Tuesday, the 27th from 9:30 to 10:30. That session will be run by Lisa Barrow, who will be going through clinical care. As Maria mentioned earlier, if you do have any other questions or if there are any specific topics that you would like further information on, please feel free to get in contact via the PICS email, which is pics.admin@rch.org.au. Nothing has come through yet. Okay. So I guess that means that you really did cover everything, Maria. Thank you.
Well, as sort of a bit of a, sweep over a very big area. But as I said at the start, I'm really happy to put together some resources. So please feel free to let me know if there's anything that I've touched on today that you'd like some more information, and I can get that to Georgia to send out. Thanks so much, Georgia.
Great. We'll wrap up then. Thank you, everyone. Have a great day.